on that website. So you can go on the website and see the presentation. Tonight I have the pleasure of introducing to you Dr. Fabio Almeida. And if you could hold your questions during the presentation, we will give you a chance to ask the questions after you're done. What we're going to have you do is just line up over here, and I'll hand you the mic. The reason I want to hand you the mic, rather than have you do it from the seat, is that's the only way we can get it on the video, so that your questions will be on the video for people to hear later on. And because the questions are a very important part of our presentation. We get things out in the questions that the doctors didn't maybe not think about, but need to explain a little more clearly. Dr. Almeida graduated top of his class with honors in the Chicago Medical School in 1991. He completed a residency and fellowship in nuclear medicine in the University of San Francisco and is certified by the American Board of Nuclear Medicine and the Certification Board of Nuclear Cardiology. Dr. Almeida is one of the pioneers in the development and implementation of cross-modality fusion and cancer imaging, better known as SPECT, PT, CT, MRI, and PET-CT. In 2005, Dr. Almeida joined the University of Arizona, where he was assistant professor of radiology and radiation oncology, and subsequently served as the director of nuclear medicine for University of Arizona Medical Center in Tucson until 2010. While at U of A, Dr. Almeida led the creation of the first combined PET-CT imaging program in southern Arizona and established the routine integration of PET-CT imaging into radiation oncology. Now as medical director of the Southwest PET-CT Institute and Arizona Molecular Imaging Center, Dr. Almeida oversees clinics in Tucson, Phoenix, Yuma, and Indian Wells. I guess he's kind of a busy guy, huh? Providing the extensive clinical expertise in PET-CT imaging. He actively participates in several oncology and neurological clinical trials and is the principal investigator for a novel carbon C11 PET agent for prostate cancer imaging, which he'll talk about tonight. The subject of Dr. Almeida's talk tonight is a superior technique to image recurrence of prostate cancer. Dr. Almeida will present the results of his research with PET-CT scans using carbon-11 acetate and for imaging based on tumors requiring increased glucose metabolism. Although other tracers have been used, C11 acetate shows great promise for earlier detection of recurring prostate cancer. Management and treatment of recurring tumors depends strongly on whether the recurring tumor cells are in the prostatic bed or outside the prostate area. Rising PSA is an indicator only of general tumor reoccurrence. But PET-CT scans using C11 alpha acetate can accurately discriminate between distant metastasis and local reoccurrence, thus permitting an optimum treatment choice. It is with great pleasure that the Prostate Forum of Orange County presents to you Dr. Fabio Almeida.
Can you hear me? Oh, yes. Sorry to hear. Thank you for that introduction, and thank you for the invitation to speak.
Dr. Almeida, hold it up to your mouth there.
About the,
there
we go, PET-CT. So I've been involved with molecular imaging for the last 20 years, and I would assume that several people in this room have had PET-CT scans in the past. It is something that, with the standard tracers that we use for cancer, which is a fluorinated glucose, a sugar, works very well for many cancers, and not very well for prostate cancer. And it's been an area where a lot of frustration, particularly for patients who are having a recurrence of a prostate cancer, in that we often cannot use our standard imaging technology to find it. So MRI, CT scans, ultrasound, as well as these FDG PET scans. And it's left us at a major disadvantage compared to other cancers that we do routine imaging and are able to usually find things and track. There's been use of carbon-11 agents in Europe actually for quite some time. So this is not exactly a new technology, but it's new to the United States because of the way that we're structured on how we can produce agents like carbon that have left us at a disadvantage. I'm going to talk a little bit about that in general, but we're going to spend a little time talking about what's different about carbon acetate in terms of PET-CT, some of the biology behind it, show you a little bit of information of the statistics of what we've seen in our patients. I think it's very important to understand no imaging test is perfect, but we need to understand how good is it and what people it is good for, and as well as I'm going to show you a number of specific cases. We're going to go through some images and give you some detail. Okay, so as I was saying, with prostate cancer, FDG is kind of our workhorse for every other cancer. So breast cancer, lymphoma, esophagus, melanoma, colon cancer, you name it, we use a fluorinated glucose. And what we're doing is we're taking advantage of a process that happens in most cancers, that they increase their sugar metabolism. They need to pull in energy in order to divide and be the malignancy that they are. And it's a process that is very common in most cancers. It doesn't happen in prostate cancer very often. So we've really attempted to use this agent in the past. We find we fail miserably with it. Prostate cancer just does not upregulate its glucose metabolism as it does with other agents. One of the other disadvantages of this is that even when we do see someone that it works in, the tracer is eliminated in the urine. So most of this ends up in the bladder. And we're very interested in the prostate bed, or the prostate gland, which is right next to the bladder. So we end up with a very hot spot that we can't see through. So just from the kinetics of the fluorinated agent or an FDG agent, we're already at a disadvantage in a very key area that we want to look at. CT and MRI, we use them a lot, but the criteria we use generally to decide, for example, if there's a lymph node that's involved with cancer, is we use size. So it has to get to a certain size before we get suspicious, we call it a pathologic node, and that's generally about 1 centimeter. And we find with many patients who have recurrence of the prostate cancer, we see the PSA going up, and it may be in a lymph node, but it takes a really long time, a much higher PSA, before that lymph node gets to a size where we're confident in calling that it might be involved. And when that happens often, we feel we've kind of missed the opportunity to go after it and treat it, because if we see one lymph node, there might be several others that are involved, and we're not confident that we can pick them out. So the basic technology just really doesn't help us with recurrence. And to a certain extent also for initial diagnosis, when we're trying to evaluate whether the lymph nodes are involved, really the same thing. There's certainly some advances in MRI with multiparametric imaging, with ferriheme, which is an iron oxide particle, which is giving us a little bit more of an edge in MRI. But there's still issues with standardizing that. It's not available everywhere. So it can be some variable results. But there's definitely progress in MRI as well in trying to help us hone in. And we find that what we're doing is very complementary to that. One of the things with recurrent prostate cancer, if, for example, this is one scenario where, for example, if someone has had prostatectomy and we see a recurrence of the PSA, one of the options is to do what's called salvage radiation therapy, so doing radiation to the prostate bed. Overall, we don't do very well with it in terms of, I mean, I guess it depends who you talk to. If you talk to a radiation oncologist, the numbers are actually reasonably good, but I would argue that we probably could do better. So the outcome of salvage radiation therapy right now would depend on the margin status, so whether at the time of surgery it had positive margins, the level of the PSA, and also the doubling time. So positive margin, higher PSA, higher doubling time, outcomes worse. One of the key pieces of information we use is somewhat arbitrary, but a selection of a PSA of 0.5 as to if it's less than 0.5 radiation therapy to the prostate bed, we consider it to be something potentially could be appropriate and successful. But even then, only 40%. And once the PSA gets above 0.5, the success rate of that is much less. What we know is we're probably missing it. So that when we're radiating the prostate bed, the disease is in a lymph node adjacent to it, which isn't getting the radiation. Or even if there's pelvic radiation being performed, perhaps there's a lymph node involved that's outside of the radiation therapy field. So radiation to the prostate bed is generally done blind. We know where the prostate bed is. We design an area around that to radiate, and if we're going to do lymph nodes, this is the same technique. It's not targeted to an area that we really know where the prostate cancer is. And that really makes it a disadvantage as we're developing better and better techniques for radiation. We need to know where the target is in order to improve on this. Okay, so we are using carbon acetate under 2 clinical trials. The reason these are clinical trials is not because they really need to be studied in the way that we're doing it, but because the FDA changed the regulatory environment for radiopharmaceuticals, carbon acetate, carbon choline, pretty much everything, as of 2012. And so anything that had not already been pre-approved or approved by the FDA needed to be performed under a clinical trial scenario. So a disadvantage from the fact that we have to do it this way, which has a lot of structure, but also an advantage in that we're collecting very important information for the FDA as to how well this test works, making sure nobody has any kind of reactions or symptoms, which we don't see, and putting some structure as well as following the patients. So after we do studies, we're following people for a fairly long period of time, continuing to follow them to see how this imaging not only detects the disease, but what impact it has in the overall treatment strategy. We have two open trials. One is with patients who have recurrence based on the PSA, and we are also looking at a trial that we have open that as part of the initial treatment strategy. So patients with high-risk disease, Gleason 7s to 10, or other high-risk factors, how the carbon acetate would impact the initial decision for surgery, the initial decision for radiation. We're going to speak mostly about the PSA relapse, but if there's questions afterwards about the other trial, I'm more than happy to speak on that. So acetate is something that's normally found in our diet. It's not any kind of foreign material. It is a molecule that our cells bring into, through their membrane, into the cells, and a little blurry for me to read here. One of the things that happens with prostate cancer is this enzyme, fatty acid synthase, is increased. So we see increased metabolism or increased drawing of this acetate into the cell, and these are eventually pulled in and incorporated into the cell membrane. So similar to what we'd like to see with the glucose, where the cell is trying to bring in nutrients in order to divide, this is one of the agents that prostate cancer actually brings in and that we can measure. There are other agents, there are other amino acids. Choline, in a very similar manner, works this way. And so we're trying to take advantage of what is prostate cancer doing that it's doing more so compared to the cells next to it that we can visualize. Okay, so this is an example of a PET-CT scan. There are really two components to the PET-CT. It's positron emission tomography, which is the molecular imaging, or we're looking at the physiology, and the anatomy is in the CT scan, and they're always combined. Part of the reason we combine them is there's some technical capabilities when we use the CT. It helps us reconstruct or actually do the math and figuring out how to make the images for the PET. But also, we can then look at all the anatomy. We always look at it in three-dimensional views, so I have cross-sections going sideways through the person, from side to side, front to back. It's a three-dimensional modality. Real advantage with three-dimensional modalities is it's much more precise as far as figuring out exactly where an area is in the body, so much less guesswork. With carbon acetate, one of the advantages also is it does not get excreted in the urine. So it goes mostly to the pancreas. The brightest area here in the upper abdomen is the pancreas, actually here as well. We see a fair amount of it in the liver and the spleen, also the heart. I'll see the salivary glands. It's important for us to actually have an agent that has what's called a normal or a biodistribution that we can visualize. Part of it is then I know that I have the correct agent. I don't want a blank screen. So I want to see some normal anatomy. That also then lets me make sure that as I'm reviewing it with the CT, everything's lined up. So my liver metabolism follows the contour of the liver anatomy. So that if then I'm seeing a spot that looks like it's a lymph node, I know that I'm right on the exact correct spot. Down in the pelvic area here, we really don't see a whole lot going on. And that's what I like to see because there's nothing in the bladder, nothing interfering. So it means if there is something in the pelvis, recurrence in the prostate bed, recurrence in the prostate gland, lymph node, they're very easy to see. So we have what's called high target to background. And it makes this a much easier modality for us to be able to interpret and do it correctly. So one of the things I just wanted to share a little bit about is the kinds of patients that we've done so far. Actually our number's a little higher than this. At the moment we're at about 270. I put this together for a presentation for the Urologic Society. Fair mix of patients who have had different procedures, so radical prostatectomy or robotic prostatectomy, radiation therapy, a combination of prostatectomy with radiation therapy, a few patients with some other things, cryotherapy, HIFU, and just androgen deprivation. When we look at the range of the PSAs that we have had in patients, fairly wide range, down to a super sensitive detection range 0.15 and up to 98. Most of these patients, though, are between this lower number and 10. That's really, I think, where we're more interested in seeing with these patients where they are with those kinds of PSAs. As far as their Gleason score, mostly concentrated in the 6 to 9, a few on either ends of 5 to 10. Most of these patients we find, those are the patients who have had radiation therapy, no prostatectomy, so their Gleason score is based on biopsy, and when we're seeing them and concerned about metastasis, it's often that they likely have been understaged, which is not uncommon with just a biopsy. Okay, so when we look at studies, there's a few parameters that we're interested in, and one of them is called the sensitivity or the detection rate. So the idea is, how often do we actually see these to be positive? Something lights up and we think it's cancer. When we look at our overall sensitivity across the board, all the patients, regardless of their PSA, it's about 83%. From an imaging technology perspective, that's a very good number. Many things that we do fairly routinely, certain CT scans, we're in the 50 to 60% range. There's very few imaging tests that we have that break 90%. And part of it is there's normal variations between people, biology, and occasionally similar or different things look similar on the imaging that we can't differentiate. So 100% sensitivity, if anybody says there's 100% sensitivity to anything, don't believe it, because it's very rarely true. Now, important for us is to also understand then how well this does at different PSA levels. It's one of the questions that often gets asked. When should we do this test? Should it be at a minimal PSA that's starting to rise, or is there some threshold? And it's one of the questions that we're trying to answer. And we found that when we're in the very, very low range, mostly below 0.4, we don't do very well. There's minimal disease there. It's really below the detection rate of any imaging study we have. And we've seen it pretty consistently be 0.4. So I actually only have one patient in this subset here that actually was positive, which was recent, and up till now, this number had been 0. So I think it's going to drop as there's more patients in this particular subset. Where we're seeing the detection rate then above 0.4, really 0.4 to just below 1, 77%. So it jumps up quite high already. And then it is proportional. So the higher the PSA, the better the detection rate. So when we combine all of this, really looking at the 0.4, we have about 86%. One of the things to really understand is also that this is an area that we are really concerned about as far as being able to help with, because the rise in the PSA when it's a low number is often the decision point of radiation therapy, if you haven't had it, or starting to think about doing other kinds of therapy. And so the lower the PSA detection that we can achieve with some confidence, it's going to help make treatment decisions overall much easier. When we follow our patients, which part of this then is, we have a detection rate, but we also want to know how often we were right. And there's a very important piece of information we really only can get through following the patients and doing some things, for example, like getting biopsies when we can, and having some other strategies to tell us that we have some kind of truth assessment. So for our studies, there's actually 3 components to it. One is histology, so biopsy proof. So for example, if we saw something in the prostate bed or in the prostate gland, the biopsy confirmed it. We have a few patients where the biopsy was not able to confirm it. I know at least one of these patients, the biopsy missed. Very confident. We're going to re-biopsy. But until it's proven, it's going to be in that negative column. The other is we'll follow imaging. So for those patients that will have subsequent imaging 6 months or a year later, MRI, bone scans, eventually if things manifest in a particular area that we were concerned about, we count that as positive. The other is there's a small set of patients who, and actually this number is a little bit higher now, it's about 26, actually almost 30 patients, who elected to have radiation therapy to the spot that we identified. Most of these are lymph nodes. A few of these are patients who have had salvage brachytherapy, so seed placement, and no other therapy. And when we see the PSA drop, we know that we've hit the target. So with the combination of these, we can get an idea of what a positive predictive value is. Certainly there's a number of patients who elected, based on what we found or other clinical reasons, to go on to systemic therapy, so hormone therapy, chemotherapy, other things. We can't really count those as far as our positive studies because those are treating the whole body. And we don't know, did we hit the target or not. So unfortunately we have to exclude that. And there are some patients who of course are just watching and waiting, depending on what we found. So we'll just have to keep following them. So when we look at what our overall positive predictive value is, it's about 88%. And so far we've been very happy with that. And that's on 125 patients so far. We actually have 270 patients who have been imaged as of yesterday. Okay, so I'm going to go through some examples and show you what these look like, and also try to give you some ideas of what was done and where we are with the results of this. So I'm going to take you through a little bit of anatomy. We're looking at a cross-section here of the pelvis. This is the front side, the back side, the right and the left. These areas here, these are the bones. This area here, this down here is the rectum, and this is the prostate gland. Okay? This is what the CT scan looks like without the carbon acetate, and the red that you're seeing here represents the carbon acetate. I expect to see the kidneys, so this is the parenchyma of the kidneys, here's the bottom part of the liver. I'll expect to see a few things in the bowel, because it goes into the pancreas, it gets excreted into the bowel, things we can very easily differentiate. So when we look at the prostate gland here, there's a very focal area of increased metabolism here of the carbon acetate along the right side of the prostate gland. Okay? So this gentleman, his history was that he had Gleason 7, he had radiation therapy, his PSA had gotten down to 0.4, and this was 4 years before we did the study, and at this point his PSA is 3.9. Negative imaging, so MRI was negative, the bone scan, CT scan were all read as negative, which is a very typical scenario. And based on this finding, this was biopsied, and it was found to be positive. And he elected to have brachytherapy, so salvage brachytherapy to the gland, and now his PSA has dropped down to 0.6. No hormone therapy, no systemic therapy. Here's another example. This is a gentleman who had a radical prostatectomy 11 years previously. At diagnosis, his PSA was 4 and his Gleason was 8. Got down to a good nadir, very low, less than 0.1. But now his PSA had been rising, so 3.3. Now here, this little white area here, this is a surgical staple. We'll often see these in the prostate bed and also along the pelvic areas. And what I expect to see in the prostate bed, which is right in this area, so here's the rectum, and we're just below the bladder, I shouldn't see anything. As far as this red color, for example. And here, I'm seeing a very defined focus of metabolism that's a recurrence in the bed. We hadn't been able to detect this up till this point. So again, this was biopsied to make sure that we're right, and it came back as recurrence. And this particular gentleman underwent radiation therapy to this area. And what's interesting about this is this gentleman was going to have radiation therapy, salvage radiation therapy, and was given the statistics. 40%, at this point with your PSA of 3.3, we're probably at a 15% success rate. He was not real enthusiastic about going forward with radiation therapy, knowing that we might be missing it, and there are potential side effects. Having this information, the radiation oncologist looked at this and said, well, this changes my plan. I'm going to give my standard radiation, but I'm going to boost this area. I know exactly where I'm going to hit, and my confidence that this is going to be successful is now closer to 100%. The important thing with this study is we didn't see anything anywhere else. So there were no positive lymph nodes. There was nothing in the bone. The gentleman underwent radiation therapy, and now his PSA is, the last we looked, was 1.1, relatively recently done, so I don't have the longer follow-up on him, but it's been trending downward. So for us, a PSA response is 50% drop from where we started. So this is demonstrating that the therapy didn't really change, but the confidence in the entire team of what we're doing and being able to relate it to the patient that we were going to be successful, significantly different than without this study. Okay, another example here. So we're a little higher up in the pelvis in this gentleman. So again, the front and the back, these are the pelvic bones here. And there's this bright area here on the left side of the pelvis. This is a lymph node that's lighting up. Here it is on the CT. Once you know exactly where to look, you can find it, and you can see, well, there's a little asymmetry, there's blood vessels right next to it, there's muscles. Very difficult image to look at. It's all gray, right? This is what we look at with CT scan. We use some contrast, we get into the blood so that we can see the blood vessels, but generally we're looking at grayscale, and differentiating small structures like a lymph node from the adjacent structures, very difficult. Even if they are enlarged in size. We add the carbon acetate, this becomes very, very clear. So we know where that target is. Here is the image looking at the patient from front to back. Here are the blood vessels up here, and there's that lymph node. So very easy to see. The details on this gentleman, he was Gleason 7. At the time of this scan, his PSA was 0.42. So, and this was 9 months after having the radical prostatectomy. So quite bright at a very low PSA. I would consider this node actually on the CT, now that I know where to look, it's a pathologic in size node. It's bigger than 1 centimeter in its small cross-sectional area. It's just not something we typically would be able to pick up on. This node was selectively radiated with IMRT, and now the PSA is less than 0.1. Okay, another example, similar kind of findings. This is a very small node here. We're looking at the pelvis, at the very top of the pelvis. So this is front to back. You can see these are the pelvic bones here. So this is the top of the pelvic rim, just to kind of give you an idea of where we are. And this is normal activity in the intestines. I expect to see that. And there's this small focus here. This is certainly less than a centimeter in its cross-sectional diameter, I think 0.8, and identified as being increasing metabolism. This gentleman had actually had a radical prostatectomy. PSA was rising. He underwent the routine salvage radiation therapy. PSA continued to go up, and at the time we were doing this was 6.9. Doubling time was at 6 months. One of the things that we're finding that I think is very interesting, I'm going to caveat it in that it's anecdotal from having looked at a lot of these, and we'll have to do the real strict analysis to see where we are, is PSA really doesn't give us an idea of where and how much is going on. So in the last example, I showed you a very bright lymph node, easy to see, very hot. PSA was 0.4. Here's a tiny little lymph node. I can make it out. PSA is 6.9. I've seen other patients with PSAs of 20 and 30, we find a single lymph node. So some assumptions that we make about the level of the PSA at a certain level, for example, a magic number of 10 or 20 means it's moved from a lymph node to the bone. Those are arbitrary numbers. And we see some trends, higher PSA, more potential that it's spread, but it doesn't necessarily hold when we actually look at the imaging studies. So something I think we're going to be able to add a lot of information to the decision-making process for prostate cancer, because we're going to be able to identify these areas much more discreetly and potentially be able to treat them. So at this point with this gentleman, this was also treated with IMRT, and the PSA is 0.9. Okay. So we're seeing a lot of lymph nodes here. I'm just trying to show you an idea that we see a lot of this with recurrence. About a third of the patients, we're finding lymph nodes in the pelvis or pelvis and the abdomen in patients who otherwise we have not been able to find where the disease is. And most of these patients have been able to treat them. So here there's actually 3 separate nodes. So this is at the level of the pelvis, down on the left side here. There's another lymph node here, a little higher up, right at the top of the pelvis, getting into what we call the retroperitoneum, or the lower part of the abdomen. And here is actually a lymph node up much higher, closer to the kidneys. Now each of these, we were able to demonstrate that to the radiation oncologist. These were treated with IMRT. PSA was 1.15, fairly low at the time, and now it's decreased to 0.18. Okay? Okay. So the other advantage with carbon acetate is it lets us look at the bone as well. So we do typically use bone scans, technetium bone scans with prostate cancer. We need things to be a certain size, in order to be able to see them on those kind of studies. It's generally a two-dimensional imaging study. It can be problematic in that the bone scan shows not only the prostate cancer, but it shows arthritis, it shows old fractures, it shows a lot of benign things as well. Sometimes it can be difficult to sort it out. When we look at the carbon acetate in the bone, when we see a lesion in the bone, it's very clear. So this is in, this is in the first lumbar vertebra, and you can see a spot right there. There's a little bit of background that we see in the bone marrow. So as we're looking at each of these vertebral levels of the bone, you can see there's a little bit of carbon acetate. It's very normal. But compared to this very discrete area, we can really see that very well. Again, the target to background. Nothing going on in the CT in that location. So the CT was negative, very clear in the spot. When we see these, radiation oncologists are very often excited about being able to go after it. Particularly if we see 1 or just 2, because we know we're catching it very early. So in this example, gentleman had had his radical prostatectomy 11 years before with a Gleason of 7, had a good initial result. Now he was on hormone therapy, and his PSA was rising despite that. So he was at 3.0 while on Lupron, and this was radiated, and his PSA has become undetectable. Okay. Another example, gentleman who had a radical prostatectomy, came to us as part of the workup for potentially getting salvage radiation to his prostate bed. His PSA was rising, it was 4.8. We found a single area up here. This is up in the neck. We're at the second cervical vertebra, so very high up in this area here. And there's an area here along the side of the bone. So this is the whole bone here, and we're seeing activity here. And this is looking at it from the side to side. And we found just this one spot. So nothing in the prostate bed, no lymph nodes, no other bone lesions. We did confirm this with an MRI, and it showed very similar results. So MRI is a very, very good test for finding bone lesions, but you have to know where to look. And he had no symptoms. We had no reason to look at and do an MRI in that area. So this gave us the target to point for. He had IMRT to this area, and his PSA has come down to 0.2. Okay. We are often combining these studies with a sodium fluoride bone scan, and so kind of the next generation bone scan. It is a PET technology, and part of the reason I like doing them is, as opposed to a technetium bone scan, we get the cross-sectional anatomy. It's much easier for us to figure out what's arthritis, what's other degenerative things, and what is prostate cancer. And the resolution of the bone scans is much better than with the technetium scans. Bone scans are looking at architectural changes to the bone. So it's not looking at the prostate cancer cells itself. And I have run into a few cases where the amount of prostate cancer actually in the bone that we're able to see on the carbon acetate is so small that it really is very difficult to see. But it's leaving a trail. So that it's changing the architecture of the bone, and we're able to pick that up on the bone scan. And there's usually a telltale way of looking at that, as far as we'll see little areas of sclerosis in the bone marrow, so in the center parts of the bone. So there have been certainly some studies where once I have the bone scan and I focus my eyes on some little architectural change on the bone scan compared to the carbon acetate, we're able to pick things up that we might not otherwise. Now, more often than not, it's the other way. The carbon acetate is very positive in the bone because we're actually imaging the prostate cancer, and the changes to the bone may not be there yet. And in our population, we're seeing people who have had negative bone scans. So if we're going to pick things up in the bone, it's generally going to be early. So this is an example. This is a bone scan. F18 sodium fluoride bone scan was done the day before a carbon acetate study. We're looking at really the same section here in the bone, of the top part of the pelvis. The bone scan is showing some area here that's lighting up. This is right at the top of a vertebra. This is very classic for what we see with just arthritis. So if I were to look at this at the side, it's right in the joint between the different levels. And we will see lots of those kinds of things in the joints, so we can disregard those. Not a whole lot going on otherwise within the bone marrow space. So this is the vertebra, this is the sacrum, and these are what are called the iliac bones here, so the pelvic wings. So when we look at the carbon acetate, there's a very bright spot over here on the left. Really can't see anything going on over here in the bone scan. There's also in the back part here, the right ilium, a very bright spot. Doesn't show up on the bone scan. And the area of arthritic change doesn't show up on the carbon acetate. So we have very high confidence that when we see things in the bone with carbon acetate, we're not looking at inflammation, we're not looking at arthritis, we're looking at the prostate cancer. This has been very important also in that when we do see a focal lesion, even when we know we can see it on the bone scan, and potentially we're going to do radiation to that area, we can help design the radiation therapy field a little bit more accurately, because we can tell the radiation oncologist where the prostate cancer is rather than what is left behind, which is what we typically see on the bone scan. Sometimes they overlap quite well, but we found several cases where the sclerosis, or what is leaving behind, is on one side of the bone, and the prostate cancer is actually on the other side. And so with the techniques that we have now for radiation oncology, we can be very precise. We want to hit the right area. Okay. So I wanted to share somewhat of an extreme example also of where the carbon acetate has been very helpful. We've seen a number of patients who have had quite a long journey as far as where they started with their diagnosis and have kind of gone through the litany of therapies and are still having issues. So this is a gentleman, 63 years old, initial diagnosis of Gleason 7, PSA of 6.6, went attempted prostatectomy, but they did the lymph node dissection first and they found a positive node. They aborted the prostatectomy. So he has his prostate intact, and at that time of diagnosis of a positive lymph node, he underwent radiation therapy, which was done to the prostate as well as the pelvic lymph nodes, and this was over a decade ago, and really never had very good control of his PSA. He had had multiple hormone therapies, combination hormone therapies, 2 cycles of chemotherapy over the years, and then some of the newer things that probably everybody is becoming familiar with, immunotherapy with Provenge. He had the Zytiga as well. He had Xgeva, and one of the issues that he had on Zytiga, he had some issues with his liver, which can happen with Zytiga, so he had to be taken off of that, and was started on Xtandi. PSA continued to rise. So he's pretty much hit all of the major therapies that were available to him, and that's kind of one of the options. So techniques in bone scan, abdomen, pelvis, chest CT, all negative. So we have probably about a dozen patients who have been in this scenario. And one of the issues with this, of course, is this line of therapy over a decade, not inexpensive. So a lot of these medications, and particularly the new ones, can be quite expensive. He was somewhat fortunate in that he, at the timing of each of these were all the clinical trials. So he had every clinical trial almost kind of in sequence. So the assumption in this gentleman was that there's metastatic disease. It's probably in a lot of places in the bone, and we're just not able to pick it up with the technology that we have. And he was contemplating potentially another round of chemotherapy with not a whole lot of hope for success. Okay, so this is his pelvis. Again, the front side, the back side, the right and the left. Here's the rectum here. This is his prostate gland. There's a very bright area here off to the left side of the prostate gland. His recurrence in the gland had gone undetected. This is a little higher up in the gland, so here, this is the bladder here, so the urinary bladder, here's the rectum, and we're getting up into the very top, what we call the base of the prostate gland, and this is extending into that area, probably a little bit into the seminal vesicle on that side. So quite extensive disease along one side of the prostate gland. When we looked at the bone windows, there's also a small new lesion here, and this is the ischium, so the back part of the pelvis and the lower part. Very easy to see. There's a little sclerosis there now. Compare it back to a CT scan from 6 months ago, nothing going on there. So at this point, he has a obvious recurrence in the gland. He's probably having his very first metastasis outside of what we know that he had in the pelvis. So his PSA that we've been struggling with for over a decade was all in his gland, and he probably did not have metastatic disease beyond the pelvis. One area in the bone. So his treatment strategy now, we biopsy the gland. Indeed, yes, it's recurrent, and he's looking at cryotherapy. So to see if we can reduce the burden. This is a little troublesome, of course, now that he has metastasized. We need to be a little bit more aggressive. But this is going to be spot radiated. And potentially, hormone therapy may still be an option for him, but we're not dealing with a lot of bulky disease. He may actually be able to get some control with hormone therapy at this point, which he's never had. So the question is, had he had a study 5 years ago, or 8 years ago, and had we been able to detect that this was a local recurrence, his journey would have been very different. Of course, this technology wasn't available, but this is the kind of thing where we're able to make a real drastic change, and even those who have had a long journey with their cancer, but as we are able to introduce this kind of technology earlier in the selection of therapies, hopefully we can make better choices, and we can go after the targets with cryotherapy, brachytherapy, or other targeted therapies before resorting to systemic therapy, or using it to supplement that systemic therapy. Okay, so in summary, we're very excited about the results that we've seen. When I compare this to the work that we do with FDG and other cancers, I think overall the accuracy is higher. One of the disadvantages with FDG, even though it's used for everything else, is it does go into inflammation. So we have to be very careful about when we image. If we do it too early, right after surgery, I'm going to be seeing false positives. Other things like infectious diseases, sarcoid, we get valley fever, they can give us trouble in that we can't tell the difference all the time. So we tend to do a lot of biopsies after an FDG study to resolve the issue. So the FDG study becomes our targeting mechanism. What do we need to look at a little further? I'm finding that with what we're doing with the carbon acetate, we have found a few other, not really false positives, but we found a few other cancers, which have been biopsy proven, but very few false positives from the perspective of, if I say it's in the lymph node, we think it's in the lymph node, it doesn't come back negative. It comes back with prostate cancer or some other cancer. And generally the other cancers that we see, we knew ahead of time based on where it was in the body or what it looked like elsewhere that we were probably not dealing with prostate cancer. And those are the very few patients. So our overall sensitivity with what we're looking at, 83%, with those patients with a PSA of greater than 0.4, 86%, and positive predictive value of 88%. Thank you. I'll take some questions.
Dr. Almeida, thank you very much. What that tells us, I think, as he said, is it gives us hope when we have rising PSA and don't know where the prostate, where the cancer is. We can detect it directly, and before we couldn't. We just had to treat it systemically. Now we can go in and zap it, because he's going to find it for us. He finds it, we get some radiation therapy of sorts to zap it on with our lives. That's something we haven't had before. And thanks to his research, we have it now. Now, what I'd like to ask you to do, if you have questions, come on up this side here, over here, and I'll hand you the mic, and he can respond with his mic so that we can get it on tape. So anybody has any question, come on up either way, either this way or that way, and we'll get your questions addressed.
Are you acquainted with Dr. Kwan at Mayo Clinic and his product, choline, which is used as a contrast agent? And do you have any comments with reference to comparing the sensitivity and selectivity of his product and yours?
Absolutely. Carbon choline, very similar concept, actually identical concept of what we're doing here. We're imaging a molecular pathway, and both carbon choline and carbon acetate, what we're measuring is the lipid or the membrane synthesis. The way we get there is a little different. With acetate, it's the upregulation of fatty acid synthase that we're measuring. With choline, it's choline kinase, but the same concept. It's PET imaging. The images look very similar, if not identical to these. The distribution of choline, also very similar, mostly the pancreas, and very good clearance so that we don't see it in the pelvis. A little bit of urine activity if you are imaging later, but we do these imaging very quickly, right after injection, so we don't see any of that. Very comparable results. So what I tell people is when they call me, basically I ask them where they're coming from. And if they're from the Midwest and they have access to Mayo Clinic in Minnesota, I say, well, you should look at that as your first option, because part of it is if you're going to be potentially getting involved in radiation therapy and it's going to be prolonged, you don't want to be traveling very far. Now, it's not that we're doing radiation therapy locally. We refer the patients back to whoever sends the patients to us. So the idea is you want to have therapy with your home team. So very, very comparable. The only real difference in our selection, for example, when we decided to work on this, we had a hard time deciding, should we do choline, should we do acetate? The Europeans use both. Very small studies that have been done, comparing it in the same patient, show that they're essentially identical. So our selection of acetate had to do with, we have 2 decades of experience with acetate. We used to use acetate as an agent to measure oxidative metabolism in the heart. So it had a long track record of safety, thousands of patients who had been studied with it. We also knew how to make it. It's a process that is simpler than choline, less expensive than choline. So part of the whole process of doing this, the exercise of doing this, is not just to study this, but is to figure out how do we make it efficiently, how do we make it economically viable, And so our whole process is to not just say how good it is, but figure out how do we make sure that then these can be reproduced in multiple areas and give people access. And I think universally acetate is just a little clearer of an agent to work with. Now, recently Mayo Clinic got special permission from the FDA to be able to use it. So they got an FDA clearance on it, which has opened the door for reimbursement, for payment, made it easier for them. And it's been a very good thing also for acetate is that it's helped the path. So I think again, I go back to where is it easier for you to get to? And there's a little bit different structure. Mayo Clinic is a very comprehensive system, and we're more of an independent facility, and we work with the local providers. And so we have patients coming from all over the country, and we work back with the physicians who send the patients to us. So it's just a little different structure.
In the interest of the other people who may have questions, you can shorten your answers for me and tell me what I need to know. The information I got from you is the specificity is about the same.
Particularly over a PSA of over 2, very similar. We are seeing a little bit more higher sensitivity with PSAs in the 0.4 to 1 and the 1 to 2.
Cost comparison. You said that yours is less expensive. I was under the impression that your charge is approximately $3,500, whereas my charge by Mayo came out at $1,250. Oh, for Medicare.
Right. See, so Medicare paid the rest of it. And that's the difference. This is under a clinical trial, and it's not currently paid for by Medicare, although we are seeing several of the private insurers are paying for it. Don't ask me how that's working. But there is a cost of $3,000 for our study, not $35,000, it's $3,000. And when I meant reduce costs, our ability to manufacture it. What does it actually cost us to make it and do the whole process? And for us, it's substantially over $3,000, but that's what we need assistance with from the patients. The actual cost to Medicare for these studies is significantly higher. I'm not going to quote the number, but it's an order of magnitude. So I think these things are going to change quickly over time as there are more centers that are going to be doing this. And hopefully we can see the costs go down, as well as coverage from Medicare. So the cost becomes a non-issue. But for now, and the structure that we have, we do have to charge $3,000 for the study.
Thank you.
Thank you, Doctor, for this new information. Thank you, Doctor. It's very clear, but for me it's new, this procedure. I think the gentleman already asked part of my question. So, if Medicare is not covered, how about the secondary insurers? Will they accept that?
Unfortunately, no.
In other words, you have to pay cash yourself.
Yeah, unfortunately, that's the structure is right now. I will tell you that part of this is when we started this, we had a fairly significant amount of funding that we didn't have to charge anybody for. And we are pursuing additional funding so we can go back to that and handle it a little bit more like a traditional clinical trial. So that our goal is not to have to charge for it at all. But with the mechanisms that we're an independent organization, not tied into a university or any direct funding from the NIH or anything like that. There is a cost, and unfortunately secondaries don't cover it yet.
In other words, the clinical trial is already over, correct?
No, it's ongoing. So we're still seeing patients. The idea of this was not to have a set clinical trial, we get to an endpoint, and we close shop, which is what happens often with clinical trials. We structured this as a clinical trial because we wanted to make this accessible. And that's the mechanism we had to pursue in order to accomplish that. So we're looking at probably another 200 plus patients in the recurrence setting, and then we'll extend that.
So in other words, you're still accepting new.
Correct.
What are the qualifications? So far I know you just mentioned about 0.4 or minus way up there.
What I encourage you to do is we have a brochure that lists the clinical trial on clinicaltrials.gov, and it has the criteria there. It's pretty loose from the perspective that we're really looking for the gentleman who have a recurrence. So the definition of a recurrent PSA which is pretty standard. If you've had a prostatectomy, 2 values above 0.2 rising. If you've had just radiation therapy, either multiple sequential rises or 2 nanograms per milliliter above the lowest point. But the idea is also that we haven't been able to find it. So negative CT scan, negative bone scan. So we don't want to throw out the traditional things that we have that are easy to get to and go right to the new technology. We want to use it as really as a troubleshooting device when we haven't been able to get there.
If I accept it, do I have to go to San Diego? There was
Phoenix. So I didn't mention this. Why is this difficult to do? Carbon-11 has a half-life of 20 minutes. So that means it disappears very quickly. Fluorine, 110 minutes, which is our workhorse. We can distribute it, we can make tons of it, we can send it all over the place. Carbon-11 has to be used on site. So we manufacture it with a cyclotron, we do all the chemistry, we do all the quality assurance, make sure it's pure, it's sterile, it meets all of our specifications like any other drug, and we have to do that in an incredibly compressed time frame. So I have a team of people who do this to produce the agent. Once it goes from the cyclotron through pass-through door into our radiopharmacy, we must use it right away. Every 20 minutes, half of it disappears. So within an hour and a half, it's pretty much gone. So it means you have to do this where you have a cyclotron capability. And Phoenix is a location where we have a dedicated center like this. There really isn't a whole lot of other centers around the country that do this. Certainly some universities have the capability, but aren't doing carbon acetate. And really nobody else in a private organization.
Are you the only one to do this? No, there's another.
At this point, we're the only ones doing the carbon acetate. Actually, I correct myself. Kansas University has a long experience of having done these. Before the FDA changed the rules, they had to shut down the program for a bit of time while they worked on getting it through the FDA, but I believe they're back up and doing it as well. So Kansas University is another location for carbon acetate. There are a few other universities who are working towards opening up their programs as well.
How about USC?
I don't believe so.
No. Okay.
Yeah.
Thank you. Thank you.
Thank you for being here. Can you tell me what is the most sensitive, if it's acetate or the chlorine?
Choline, similar sensitivity.
Similar.
So I don't think that there's really any evidence to suggest that one agent is vastly superior to the other.
Can you tell me if this test is available to those who are on hormone therapy?
We do routinely see people who are on hormone therapy in the case where the PSA is rising on hormone therapy. So if you're in a position where the hormone therapy is actually suppressing the PSA and doing fine with that, we're going to have a negative test. So a flat or downward trend of the PSA, we're not going to see metabolism because we're measuring that activity. Part of the strategy, if there's a question of can we find it in someone who's been on hormone therapy, is we wait until they're due for their next shot, hold it, and so we put them on a mini holiday, and we see what happens with the PSA. And then we schedule this for a comfortable period as far as where the target PSA is. Those who have been on a holiday usually have a really good idea of how long it takes for the PSA to get up to that point where they have to go back on hormone therapy. So it's mostly just a matter of working with the individuals, what's the strategy, and also what are we trying to accomplish. So the idea of doing that would be, we have no imaging evidence specifically where it is, and the intent would be that if we find something off of hormone therapy, that you're willing to go after it with radiation therapy or some other thing to get rid of it. If it's just to find out where it is without any intent of changing the treatment, then it's probably not something you need to do. Thank you. You're welcome.
Stand by for a long question.
I'll behave. Hi.
Hello, I recognize
I
you.
saw him at the prostate cancer.
Yes, PCR.
Okay, my dear. So basically, a husband who's had a radical prostatectomy, I hope I said that right, some years ago, but the PSA is slowly rising, but it's rising.
How slow?
Well, it's about, I'd say, 2/100ths, perhaps, every month. He's having PSA tests done monthly. All right, so coming to the point, nothing's been done other than the surgery, and that was about 10 years ago? Yeah, okay. And now it's slowly moving, but it's moving, so we're watching it. So here comes your C11 acetate PET CT into this picture. If he, at now 0.26, very low, but we're watching it. I'm hoping he'll still be in business doing this when the time comes for him to use it. Let's trust you are. Meanwhile, we're getting towards that 0.4 or between that and 1. We come to have it done. It's done and you don't find anything. Then when and could it be repeated? When would it be wise to, and could it be repeated, since nothing's been done thus far other than the surgery and now the recurrent number?
Good question. And it is not an uncommon situation. So a slower rising PSA, doubling time, 12 months, 2 years, we see that. The cells are very slow. They're not going to take up a lot of carbon acetate. So that's part of the reason why with that 0.4 and less, we don't see these. So I have seen patients with much higher PSAs with very, very slow movement, and they will come back negative as well. So having a negative study at a 0.4, when we get to that 0.4, 0.5, is certainly a possibility. But what it does give us confidence in is that we're not missing something obvious. A lymph node that can be treated, or something in the gland that can be treated, or potentially a bone metastasis. Our strategy has been to look at what the doubling time is and repeat the study when it's doubled yet again. So if we did the imaging at 0.4 and it was negative, we'd wait until 0.8 to 1 to repeat it. And so that could be a year or two later, potentially. And that has been part of the strategy is, if it's a low PSA and it's negative, again, I think we have some confidence that we potentially can watch and wait. And we don't really need to do anything. As opposed to if I find a bone metastasis, for example, at 0.4, we need to go after it. Or at least you need to know about it to put it into the options of how to treat it. So it gives us some confidence that we can do some potentially watchful waiting and make sure that the PSA isn't changing its trajectory, because if it all of a sudden does start to speed up, then we need to change when we do it. The idea is to find this as early as possible with the potential of being able to do targeted therapy.
So by 1, it would be a thought to come say hello to you, assuming you're still doing it.
Not unreasonable. And the assumption should be, yes, we will be doing this, because when the clinical trial is over, is because we've gotten it FDA approved, or we're moving on to a more sophisticated trial, but we plan on doing carbon acetate or a similar molecular imaging agent that's trying to accomplish the same thing at our center.
And the amount of the amount of radiation you're utilizing is?
Compared to a regular PET scan, is actually less. This is radiation. We are doing an injection of radioactive material. It's equivalent to chest, abdomen, pelvis of a CT, which we usually do at a higher energy. So very similar to standard imaging. But we should be prudent. We don't do repeat PET scans on somebody once a month. We do like to make sure that, unless there's a real reason to do it, that we're trying to troubleshoot a very specific issue.
Unless the doubling really picked up fast.
Well, even then, once we find it, we treat it. We're not going to be doing multiple PET scans and multiple imaging to confirm it afterwards. We have other ways of knowing if we've got the target. The PSA drops, we're happy. So we don't need to do sequential imaging. But like anything else, with any other imaging that's going on today that uses radiation, we're trying to be a little bit more prudent about not over-imaging, so that we're not repeating CT scans at a frequency that's going to put someone at risk. The reality of that that's stemming from is We do a lot of CT scans for people when they go to the emergency room, and a lot of children, a lot of young women, and we're probably doing too many. And so that's really where a lot of the concern for imaging radiation stems from. And if we're dealing with someone who has cancer, the trade-off of finding it to be able to deal with it versus the potential of some issue we might cause in a decade or two, we have to use a little bit of common sense.
And the hope is that Medicare could eventually approve this.
Actually, that will be very much the goal of this. Right now, Medicare actually changed some of their rules such that as soon as another agent like this, or this agent, is FDA approved, it will be reimbursed by Medicare. They've opened the path for novel radiopharmaceuticals, and again, the work they did at Mayo really is what plowed the road for that. So they did a tremendous service for everybody in this field, whether they're using carbamazepine, acetate, or any other similar molecular imaging agent.
Thank you for providing hope. We appreciate that.
I had a prostatectomy and recurrence. From the prostatectomy, I had a nasty stricture and I'm very reluctant to have them radiate the prostate bed. Dr. Scholl's has been talking to me about coming to see you. What's your percentage, if you know, of where you found recurrences in a prostate bed versus elsewhere?
We're finding, when we just look across everybody, it's about a third of patients we're finding it in the bed or the recurrence in the gland. About a third of the patients we're finding something in the lymph nodes, and about a third we're finding in the bone. And pretty much across the board, regardless of where they started, and regardless of what their PSA is. I have a slide that I was showing in the conference, which tried to illustrate it. It looked like a rainbow. It was actually very confusing, but the point of it was that the PSA really didn't tell us as much as we would have liked. And this is something we're going to have to look at this very strictly and look at all the parameters and seeing what manifests itself. But yeah, so 2/3 of the time when we think it's a recurrence in the prostate bed, we're wrong, or it's not only in the prostate bed.
I've had color Doppler and Dr. Blom, and also PET scan at UCLA.
What kind of PET scan? FDG?
Whatever, I don't know. This is several years ago. But anyway, I've been on 2 courses of hormones, and we just went through rev up your immune system thing. They just took me off of that. But my PSA has been being controlled quite well, but it's expensive, and I don't have a lot of it. It'd be nice to know where it is and if it's at. But
Well, one of the things...
more scarring in that stricture area.
And it's a very reasonable consideration. One of the things that is a little difficult when we incorporate carbon acetate or carbamazepine, it is new technology. We would like to quickly adopt it and just replace or change our direction of how we do things. But it's not really how we should do an analysis of imaging and how it works. So in order for us to really understand how well it works, we still have to do some of our traditional things. So what I'm kind of getting to is that, say we do the imaging and I find a lymph node in your pelvis, and you haven't had radiation to your prostate bed. Most radiation oncologists are going to say, great, I can hit that lymph node, no problem. But I'm going to do the prostate bed and the rest of the lymph nodes because that's standard of care. So the carbon acetate study may not necessarily change that option of being able to avoid it to the prostate bed. I have some radiation oncologists who will just bypass that and go after that lymph node. But that's outside of normal care. And so it's something where we have to be careful not to get too far ahead of ourselves in understanding how this works. The goal will be an imaging study like this, if we identify that lymph node, and our studies show very substantially that if you radiate just that lymph node, that your outcome is just as good or better because of lack of symptoms and other things than what we traditionally do, that's a home run. But that takes structure, and that takes us some time. So it's one of those things just to kind of manage your expectations of what we're doing. I definitely have patients who are in a very similar situation as yours, and they've been a little frustrated they've gotten good results, they have a lymph node, they have a target, but those who are managing their treatment are very traditional and saying, yes, great, I'll go after it, but I still need to radiate your prostate gland, or the prostate bed. So, something to think about.
Thank you.
This is a little different kind of question because of your expertise that I'm asking. In the beginning of your lecture, you talked about the fact that regular PET scans are not that reliable for prostate cancer. I've had 2 over the last couple of years that lit up on the prostate, and I'm really concerned about what that means. On a regular PET scan.
On an FTG PET scan.
Yeah.
And those have been proven to be recurrence?
I'm not in recurrence. I haven't even gotten to the stage of even being diagnosed that I have prostate cancer, but it looks suspicious. And it's in fact the only test that I've had that looks suspicious because I had an MRI and I did a lot of other tests just after I got the PET scan and wanted to just see, is this cancer or not? Digitally, there is a little nodule. Okay, what I'm trying to say is this lighting up, some people have told me that for it to light up on a normal PET scan, it has to be pretty advanced.
Or it could be prostatitis, or it could be a benign adenoma, or it could be BPH.
That's what I was wondering
And
about.
that's really the problem with FTG scan. And to a certain extent, even carbon acetate and carbon choline, this is not a test that we're going to be using to make the diagnosis, because there are other things that will have increased metabolism. So, as I was mentioning before with an FTG, we see inflammation. If you have an area of infection or inflammation in the gland, it's going to light up. So I see that all the time in gentlemen that I'm doing FTG scans for other reasons. Say, for example,
the lungs actually is
Right.
what they were doing.
And so my experience is, or what I would say about that is, I alert people that it's possible that it could be prostate cancer. But it needs to be correlated with the PSA, it has to be biopsied if we're going to go that far. That's really the way that
I'm
we're
trying to
find
avoid the
out.
biopsy, but I'm going to have the color Doppler and see some of the things.
Yeah. So, but even color Doppler. Color Doppler takes advantage of increased vascularity, increased blood flow. We see increased blood flow with prostatitis. Infection, you get inflammation. So there's a lot of crossover that when we're looking at it from, when we don't know what the diagnosis is, there can be some confusing things. And carbon acetate, carbon choline do not resolve those issues. So we don't do the imaging, for example, on anyone who does not have a diagnosis of prostate cancer. And I have an idea of what the Gleason score is and what we're looking for. So down the line, will there be an imaging agent that we can make a diagnosis, or at least select people out that we know we really need a biopsy? I think there's some things on the horizon, but we're not there yet.
Again, thank you for coming and sharing. You said that after you're imaging, lights up an area, they do IRMT.
IMRT, intensity modulated radiation therapy. Radiation therapy has evolved from the concept of kind of doing a field of radiation front to back, side to side, kind of wide swaths, to very precise conformal radiation. So if we can identify an area, we can design the radiation to hit that one spot. There are a number of forms of radiation delivery that can do that. And generally, IMRT is one term that's used to describe them, or conformal radiation therapy. Another term that we use is IGRT, which is image-guided radiation therapy. And all of them are taking advantage of computer technology, CT imaging, integrated in with the radiation therapy plan, so that we can deliver a very precise beam to where it needs to go and avoid the things we don't want it to go to.
Thank you.
Thank you for that excellent presentation, Doctor. One of the questions that may be in the minds of some of the people here is you have great sensitivity, somewhere around 90%. Okay, the PSA is over 2.0. Once you identify precisely where the cancer is, if a person has cancer, prostate cancer. Could you kind of explain how you would hand that information off to a
Radiation oncologist, for example.
here in Southern California? Because most people, can't travel that easy. I mean, so how do they get the information that they have confidence that information will be followed so that the cancer can be precisely addressed, please?
So one of the advantages with PET is we do use this routinely for other cancers that then those patients go to radiation therapy. So the imaging, the cross-sectional imaging is done at our facility in what we call radiation therapy position. So we do the setup on flat table. We emulate the positioning that the patient may be for radiation. So one, we're trying to eliminate a major body difference in how we deliver that. CT scan, the PET scan, actually all radiation oncologists can really integrate that information into what's called a treatment plan. So they do what's called a planning CT, for which they base the plan on, and they can bring other imaging into it and actually fuse it. So that's a technology that's very common, so it's nothing new for prostate cancer. The main aspect of this is we're able to pinpoint where these areas are, where they haven't been able to do it before. We add a few extra aspects to it when we do it. I do actually contour, provide pretty much X marks the spot on the CT, so we integrate the information into the CT scan so that the radiation oncologist, when they're running through the scan, there's no question. Here are the exact spots where we're seeing metabolic activity, and they have the CT scan, which has all the exquisite anatomy from our study, and they can fuse it directly into their CT study, and all the anatomy lines right up. So it's a process that can be done visually, side by side, but when we put it all together, we make the time commitment that a radiation oncologist has to put into knowing where are the areas that I need to focus on into a few minutes, and so they really appreciate that. And so it's just all streamlining the workflow so that we can really maximize what we get out of the studies.
Thank you, Dr. Almeida. I know that historically there's always people that want to talk to the doctor one-on-one. And if you so choose to do that, would you please do it behind our camera here, because we need to tear down and people get their feet caught in the electrical wires and bad things happen. So please, if you want to talk to Dr. Almeida, talk to him behind the camera area there so that we can clean up and get this electrical done. Now you all know that, well, one thing you don't know, Dr. Almeida flew in from Arizona today just for this meeting. So he took a lot of time out of his schedule to come and address us tonight. We really do appreciate that. We've all heard that time is money. We don't have any money. So we can give him something to save time. We have a Prostate Forum coffee cup here that he can sit in his car. He doesn't have to waste time drinking his coffee at the kitchen table. He can drink it on. Thank you very much, Dr. Almeida.
Michael.